So, hello everyone, and welcome to my presentation on D-dimers, an old marker tricky to use in daily practice. So, 1973. This is the year when the research group first described this unique fibrin degradation product that is called D-dimers. And to give you an idea, it was 50 years ago. So what happened 50 years ago? 50 years ago, it was the years when the first personal computer was created, the Xerox Alto. It was also the year when the first space station with a research laboratory was sent in space. When the first phone call was made, so it was a really long time ago. And for you, for sure, the most important event of this year, it was the release of this album of Charles Aznavour, Aznavour chez lui à Paris. So, before talking about D-dimer, we have first to talk a little bit about the process of fibrin degradation, fibrin formation, and fibrin degradation. Fibrin formation is initiated by the fibrin cleavage of fibrinopeptide A and B from fibrinogen to produce fibrin monomers, association of soluble fibrin monomers to form soluble fibrin polymers, then factor 13, which is also activated by thrombin, will stabilize the soluble fibrin polymers by introducing covalent bond between fibrin strands, and the final products will be called cross-linked fibrin. After that, plasmid enter into the game and will initiate the degradation of fibrinogen and fibrin. Note that both degradation products are similar, except for D-dimer fragments that are specific to the degradation of factor 13 cross-linked fibrin. And so we can say that D-dimer fragments reflect both activation of coagulation and fibrinolysis. D-dimers, as you probably know, are increased in many situations. Any process that increases fibrin production or degradation. And in the end, there are only two consolidated clinical applications, venous thromboembolism and disseminated intravascular coagulation. All other situations should be considered in the interpretation, but they are more considered for their ability to produce false positive for the other diagnosis. So for this presentation, I suggest to focus on the exclusion of DVT and PE and to present you all the challenging cases and all the tricky factors that can mislead you in the interpretation in D-dimer test. And so the first thing to talk about is why we cannot use D-dimers alone to exclude DVT and PE. So in fact, it's easy when we know it. It's because the negative predictive value of a test is directly influenced by the prevalence of a disease. And if you look at the formula of the negative predictive value, you can see that this formula depends on the number of true negative and false negative. And if you increase the prevalence of VTE in your population, you will increase the number of false negative results. And if you increase the number of false negative results, the negative predictive value will decrease. So to sum up, as the prevalence increases, the negative predictive value decreases. So that's the reason why, if there is a suspicion of VTE, the first thing to do is to estimate the clinical probability using a score. And the two most used scores are the Wells and the Geneva score. Overall, so this is more an overall rule. the prevalence of VTE the prevalence of VTE is less than 10% in patients with a low clinical probability. The prevalence of VTE is approximately 20 to 30% in patients with a moderate clinical pretest probability, and it is more than 50% in patients with a high clinical pretest probability. So, in a typical VTE diagnostic algorithm, patients who are scored as low or moderate have a D-dimer level drawn. If the D-dimer result is negative, VTE is considered excluded thanks to the high NPV of almost 100%. On the other hand, if the D-dimer result is positive, it increases the probability of a positive diagnosis, but without confirming it, and so imaging is still necessary. If the patient has a high clinical probability to have VTE, D-dimer is omitted and imaging testing is performed immediately because in this case, the negative results for D-dimer does not exclude VTE, and many patients with high clinical probability have conditions that are associated with elevated D-dimers, so such as cancers, post-surgery, and so on. So theoretically, it's simple. In daily practice, it's a little bit more complicated. So to interpret correctly D-dimers, we have several factors to consider. And the first thing to consider are the factors related to the clot itself. So among patients with VTE, D-dimer levels vary with the clot burden. So among patients with DVT, higher D-dimers level are observed for patients who have thrombosis extending above the level of the knee compared to patients who have thrombosis confined to their calf. That is to say, proximal DVT versus distal DVT. Similarly, among patients with confirmed pulmonary embolism, higher D-dimer levels are observed for patients with larger emboli. So here, for example, in this study, you can see that the sensitivity was excellent for segmental and larger pulmonary embolism, while it was insufficient for subsegmental pulmonary embolism. Then, among patients with VTE, D-dimer levels vary with the timing of measurement and the initiation of a treatment. Typically, there is a peak of D-dimer levels at day 2, and so this level will gradually decrease until losing its diagnostic potential approximately 1 week after symptom onset. There is also a decrease of D-dimers in patients with acute VTE approximately 24 hours after starting heparin therapy. Depending on the publication, this reduction has been estimated between 25 and 50%. So to sum up this small first part, a distal DVT, isolated subsegmental PE, more than 7 days after symptom onset, and concomitant anticoagulant treatments are all possible causes for false negative D-dimers. Okay, so for this part, usually it's quite easy. Then the second factor to consider, which is very important, is the D-dimer assay that you use. So why? Because there is a high variability between the various D-dimer assays, because these assays are not specific to the final degradation projects, and rather identify a heterogeneous mix of polymers with D-dimer antigen. And each assay will identify a different mix a different mix of polymers with D-dimer antigens, depending on the epitope that is recognized by the monoclonal antibody. So the assay do not recognize only this, but this, part of this, part of this. Then, this variability is amplified by the absence of standardization. That is to say, the different D-dimer assays that are on the market are not calibrated to a common standard. Here, these figures show you the data from an international external quality control program from 2017 to 2022. And you can see that the variability is significant, especially at the typical VTE exclusion thresholds, with CV often ranging from 10 to 20%. Which can be a lot. For example, if you have a patient with a level of D-dimers at 450 nanogram per milliliter, a CV of 20%, it means that you can have a positive or negative results. And this is what I say here. For clinicians, variation in assay types means variation in performances. So this table summarizes the finding on several studies, and you can see that depending on the type of assay used, the sensitivity of the test will range from 82% to 97%, and the specificity from 43% to 72%. So it means that all D-dimer assays are not suitable for the exclusion of DVT and PE, and by extension, the results of clinical studies performed using one assay cannot simply be extrapolated to another. So to sum up, an insufficient method sensitivity is another possible cause for false negative D-dimers. And how to be sure that you have an assay that is suitable for D-dimer? It is highly recommended to use only D-dimer assays that are validated for the exclusion of VTE. So what does it mean? What does it mean concretely for this assay? It means that this assay has been designed to be very accurate and very precise, close to the 500 nanogram per milliliter cutoff, such as, for example, the STA Liates DD+. And to prove that, the assay has to satisfy FDA and CLSI requirements in terms of sensitivity and negative predictive value. That is to say, all assays that are validated for the exclusion of VTE will have a sensitivity above 97% and a negative predictive value above 98%. So then, okay, so we talked about the clot itself, the D-dimer assay, and it brings us to this part of the presentation, which is the clinical context. Because in theory, the traditional algorithm that use clinical pretest probability and D-dimer assay works well for patients who do not have comorbidities. But the problem is that in many cases, it's not so efficient. So there exists method, especially algorithm, that allows us to improve the specificity of the test while keeping the negative predictive value close to 100%. So this is what I wrote here. So to increase the specificity while keeping a negative predictive value close to 100%, two approaches for interpreting D-dimer results have been proposed. So the first one is D-dimers increase with age. So the first approach that has been proposed is to use an age-adjusted cutoff after 50 years, which means the cutoff will be the age times 10 nanogram per milliliter. So for example, for a patient who is 70 years old, the threshold will be 70 times 10 equal 700 nanogram per milliliter. The efficiency of this approach has been demonstrated in a large multicenter prospective study, the ADJUST PE study, which compared the performance of the standard and age-adjusted cutoff in outpatients that come to the emergency department with a suspicion of pulmonary embolism. And concretely, what are the results in this study? In this study, there were 2,898 patients with a low or moderate clinical probability of pulmonary embolism. Among these patients, 817 had a D-dimer level below 5 nanogram per milliliter. So for sure, the vast majority of these patients did not have a pulmonary embolism. But what is interesting is that 337 patients have a D-dimer levels between 500 nanogram per milliliter and the age cutoff and the age-adjusted cutoff. And in this population, you can see that the number of false positive was the number of false negative was the same than for patients with D-dimer levels below the standard cutoff. What does it mean? It means that using age-adjusted cutoff is as safe as the standard cutoff, but allow you to decrease the number of imaging testing that is necessary in your patients. So in this study, there was a 41% increase of true negative without any additional false negative findings. So if you apply that in real life, these 337 patients do not need imaging testing. And the results of this study have been validated a few years later in a real-life study, the RELAX PE study. And as usual in medicine, this real-life study confirmed the results of the first study, but with performances slightly lower than in the first study. The second approach that you can use to increase the specificity while keeping a negative predictive value close to 100% is to use a clinical pretest probability adjust cutoff, which means that instead of using, for example, the 500 nanogram per milliliter cutoff, you will use a different cutoff depending on the prevalence of VTE in the specific group of patients that you analyze. For this approach, I have two examples. The first example is the 4D algorithm, which is applied for the suspicion of DVT. So in this algorithm, they suggest to use, at presentation, so usually you use the 500 nanogram per milliliter cutoff for patients with low and moderate clinical probability. And in this algorithm, you will use a 1000 nanogram per milliliter cutoff in patients with a low clinical probability. And then, to determine the need to repeat ultrasonography, a 3000 nanogram per milliliter cutoff will be used in patients with a low to moderate clinical probability, and a 1500 nanogram per milliliter cutoff will be used in patients with a high clinical probability. And overall, this approach reduces the need for scheduled ultrasonography by 47%, once again, whilst while safely excluding DVT. In the same way, the second example is the years algorithm, which is applied for the suspicion of PE. And in fact, this algorithm is really important because maybe you already know that, or if you don't know that, this algorithm is currently tested in many other applications, in many other group of patients who are difficult to diagnose because it works really well. So what is the years algorithm? In fact, it's very simple. This algorithm combines a simplified clinical assessment, which is based on three clinical elements of the Wells score. So the presence of signs of DVT, hemoptysis, and the fact if pulmonary embolism is the most likely diagnosis or not. And this simplified clinical assessment will be combined with differential D-dimer values depending on the presence or absence of this year's criteria. So if there is no year's criteria, the D-dimer cutoff that will be used is 1,000 nanogram per milliliter. And if there is at least 1 year's criteria, the D-dimer's cutoff that will be used is 500 nanogram per milliliter. And once again, so always a little bit the same thing. With this algorithm, you can see that you can decrease the number of CTPA by 14%, while safely rule out PE in comparison to using the Wells score with a fixed cutoff for D-dimers. In the article, they also tried another thing. They combined this year algorithm with the age-adjusted cutoff. And they found an interesting thing, which is for patients who do not have years criteria, if you have a D-dimer levels below 1,000 nanogram per milliliter, but above the age-adjusted cutoff, you have to be careful because you have a slightly higher rates of false negative. So you can miss few cases of pulmonary embolism. So, okay, it's cool. There is two approaches, but maybe you can ask one fair question. Okay, so which strategy to choose in the end? Age or CPTP adjusted cutoff? There is no, so unfortunately there is no definite answer, but a recent meta-analysis demonstrates similar improvement in specificity for both strategy in patients with a suspected DVT. So basically in this table, you can see that when they applied the CPTP adjusted cutoff and the age adjusted cutoff, they had the same negative predictive value as the standard cutoff, and they have 10% more specificity approximately. So the takeaway of this slide, of this part, is it is better to use an age or CPTP adjusted cutoff than the standard cutoff, but you can use whatever approach, the approach that you prefer. Globally, for most patients. Okay. And so there is the last part. What about the specific populations? Because even if we advance in the presentation, okay, so now we know a lot of tricky situations that can provide false positive results with the D-dimer assays, but it remains the specific population that are a large topic. So what I mean by specific population? The first category is pregnant women. Because the problem is pregnant women, is that D-dimer levels steadily increases over the course of pregnancy. And it is very common that the D-dimer levels is above 500 nanograms per milliliter at the end of the pregnancy, and even during the second trimester. So so D-dimer assay is not reliable in this population. Moreover, there is a peak after delivery, and the return to normal is expected approximately 30 days postpartum, and for some women it's even more close to two months postpartum. So in the end, the classical approach, clinical probability plus fixed D-dimer cutoff, is unreliable during pregnancy and during the high-risk period of immediate postpartum. And this is a problem because, as you know, pulmonary embolism is a major cause of maternal death. And for this woman, the current recommendation is to use the CTPA as the standard diagnostic method. So it's very efficient. By definition, this is the reference method. But this method exposes mother and child to risks from radiation. So some people, once again, try to find an alternative to decrease the number of CTPA needed in pregnant women who are at risk of VTE. So what has been done? The most interesting study for this population, the most interesting algorithm is the Artemis algorithm. In fact, this Artemis algorithm is very simple. It's exactly like the years algorithm, but just with one additional item here. So this additional item is that if your patients have clinical symptoms, of deep vein thrombosis, you will perform a compression ultrasonography of the symptomatic leg, and if the result is positive, you initiate the anticoagulant treatment without the need to perform any other testing. And if the result is negative, you follow the years algorithm. By using the Artemis algorithm in pregnant women, in this study, CTPA was avoided in 32 to 65% of patients, and the highest reduction was observed during the first trimester, when radiation is potentially the most harmful for the fetus, for the embryo. Okay, so pregnancy is the first special population. The second special population is patients with renal impairment. Because the problem is that part of the D-dimers is eliminated by the kidney. So logically, D-dimer levels increase with declining renal function. For these patients, there is no official recommendation, but there are several publications. Some publications suggest to use a cutoff, a D-dimer cutoff that is adjusted with the level of renal impairment. But when you look at in details in the publication, you can see that in fact it's not a reliable method. And I think this study, this letter to editor, gives you, explain to you why it is not useful to adapt your D-dimer cutoff depending on the level of renal impairment. So if you look at the part A of this figure, so here you have the crude relationship between D-dimer's level and the degree of renal impairment. And you can see that D-dimer levels increase concomitantly with the declining renal function. So, okay, so yes, there is a correlation between the two. But after that, when you look at the part B, in part B, you have the relationship between the D-dimer levels and the degree of renal impairment but after adjusting for age. Because you know that older patients are more prone to have a renal impairment. So if we take into account this factor, you can see that in fact, the degree of renal impairment do not impact the D-dimer levels for patients with low and moderate renal impairment. There is only an impact for severe renal impairment. And when you look at the part C of this figure, which is the same but after adjustment with age and CRP, you can see that there is no association at all between EGFR and D-dimer levels. So what is the takeaway of this slide? The takeaway is renal function adjusted D-dimer thresholds in patients with renal impairment is not necessary. The validated age-adjusted D-dimer threshold should be preferred for patients with mid or moderate renal impairments. So this is a fact, and this is used by many people. And the second part, it's more a suggestion than a recommendation. CRP-adjusted D-dimer testing might be useful for patients with severe renal impairments. And now, the last category of special population of patients that I wanted to talk about is patients with cancer. So many cancers correlate with systematic hypercoagulability and high D-dimer levels. So this is a fact. You can see many cancers, and depending on the cancers, there are several mechanisms that can cause the elevation of D-dimer levels. Many studies have also been conducted to prove that the extent of D-dimer elevation can be linked to the tumor stage, progression-free survival, overall survival, and even cancer recurrence. So maybe we will be in close future in the clinical field one of these applications. For the moment, it's more science that clinics, because there are many studies, good results, but it's not used in daily practice a lot. But the problem is that this increase of D-dimer levels in cancer, so it's cool for this potential indication, but for our purpose, which is the most important indication of D-dimers, it also reduces the specificity when D-dimer is used to exclude VTE. So this is what this table shows you. So this sentence is a repetition. So cancer is a well-known risk factor for VTE, but the loss of specificity decreases the clinical utility of the traditional algorithm, clinical probability plus fixed D-dimer threshold. So this is a literature review that summarized the data of several studies. And as expected, you can see that the specificity is always lower in patients with cancer than patients without cancer. So it's quite logical, in fact. And so in these patients, what clinicians do in daily practice, they use imaging testing directly. And And so there is currently a trial that is trying to find an alternative. This is almost always the same thing. So this is a trial that is called the Hydra algorithm. And so this is an ongoing multi-center international trial assessing once again the year strategy in patients with cancer. So you can see that the years algorithm is really important because we try to use it in many categories of patients. But for cancer, not that this algorithm has the ability to decrease the number of CTPA necessary, but this time the number of false negative results is higher than for the other indication. So this is not, it will not be the magical solution. It will be complementary tools with what exists today. So to sum up the information in this presentation, so D-dimers assay cannot be used alone to exclude deep vein thrombosis and pulmonary embolism. We have to combine this D-dimer assay with the clinical pretest probability. And when you do that, you have to consider many factors related to the clot itself, which is the clot burden, the timing of measurement, and the concomitant anticoagulant treatments. You also have to consider the D-dimer assay that you use, especially, once again, it is highly recommended to use a D-dimer assay that is validated for the exclusion of VTE, because these are the only tests that are reliable close to the 500 nanogram milliliter cutoff value. And third, in addition to this classical approach, you can use age-adjusted cutoff or clinical pretest probability cutoff to improve the specificity of your diagnostic approach. And for specific population, there exists other algorithms that can help you with your patients, and especially algorithms that are adapted from the year strategy. So it brings us to the end of this first presentation, and I thank you for your attention, and I am open to any question you may have, because in fact D-dimer is a vast topic. I didn't know what to talk about, and it seemed that the best idea was to talk about the exclusion of VTE, because this is the most common indication, and so it's more applicable to daily practice than maybe more innovative indications that are currently evaluated. So thank you for your attention.